Welcome to our podcast. My name is Amy Blum, and I am the Chief Operating Officer at the National Gaucher Foundation, an independent nonprofit dedicated to serving U.S. patients with Gaucher disease and their families. Through financial support, educational programming, patient services, and collaboration with medical professionals, NGF empowers Gaucher patients to live a better today. Today's podcast will focus on the Affordable Care Act, ACA. What is it, and what is at stake for our community should it be repealed? And I'm thrilled to welcome back our special guest, Claire Sachs. Claire has been a cog in the wheels of big healthcare for over 30 years. She has been a patient beginning from the young age of 6, as well as a caregiver. She built a team to help her stay on track of her medical needs. She has managed complicated insurance coverage, studied policy, and acted as a counselor to friends, families, and colleagues. She has clarified the system for them, helped them avoid painful mistakes, and advised them how to make themselves heard. Now she shares her expertise with you, a diverse patient community, throughout the country through her weekly e-newsletter and blog posts, the Patient Advocates Chronicle, as well as here with us today. So Claire, welcome to our podcast, and thank you for joining us again.
Hi, Amy. Thank you for having me.
So let's just jump right in because this is such an important topic and there is so much to discuss. Probably the best place to start is let's just do a little recap of really what is ACA, when was it legislated, and when did it roll out? The very basics, just so our community who's listening has that point of reference before we really dive into the real reason why we want to talk, which is currently what is going on legislatively, talking about the possible repeal of ACA and what that will mean for our community. So let's start just a little bit about what is ACA?
So the Affordable Care Act is a law that was put into place in 2010 by the Obama administration when they had the backing of both houses of Congress. They were in the majority. Democrats were in the majority in both the House and the Senate. So that was their time to move. And I know that there were a lot of people who were pushing Obama to use his political capital on something like infrastructure, a little less controversial. But he said, no, we're pushing through this comprehensive law. And the idea behind it is to expand health insurance coverage through public options based at the federal level and at the state level to a much broader community. There were a lot of people, millions, without healthcare, including many children. And so in a lot of ways, this reached out to those underserved populations and at least got their foot in the door.
And this is also why you hear this conversation about healthcare should be just a right. It's a basic right for all American citizens to have access to healthcare and to be able to.
And it's amazing, actually, the way that came about, because before the ACA was introduced and passed, people didn't think of healthcare as a right. It was sort of a perk of a good private job, or a government job, or you got Medicare when you aged into it, or if you were disabled or in need, you got Medicaid. But there was a gap in that coverage that nobody was serving. And it's taken less than 10 years for the national way of thinking to be, oh yeah, this is a right. I have a right to be healthy in my own life. And so if you're talking about major changes in perspective, it's amazingly fast because it's a cultural change, and cultural change almost never happens in less than a couple of days.
It makes sense that this is such an important topic that culturally there's been the shift so quickly because everyone during their lifespan is impacted by health. So it's easy to jump aboard and say, wow, now if we're going to talk about it like this, and this isn't just a pie in the sky dream, it makes sense and we're behind this in so many ways. And there are controversial aspects to it. So we're going to kind of touch on that also today. But I think that to understand how, as you said before, the law was passed in 2010, and it basically rolled out by 2014. And there were two major areas that impacted this substantial change in the way in which we look at healthcare now. One was the expansion of the Medicaid eligibility, and the other, which is multifaceted, is the major changes in the individual insurance markets.
Yeah.
So the major changes were really radical.
They were. It was painful at the time. Everybody was against it because it had no Republican support when it was passed. But now that we have arrived where we are, people have it. And it's a lot easier to take away, or a lot harder to take away something that people have than to give them something that they've never had.
Right.
So they've adjusted.
Right.
But yes.
So we now know that we've become accustomed to the fact that the markets have to accept all applicants and charge the same rates for the age brackets, right? Depending on your age bracket, they cannot look at pre-existing conditions, which was huge. And for our community, as well as any community that deals with a chronic health need, is enormous.
Right. It's the biggest for me. And I don't know how much people remember from before 2014, but before this was mandated, under HIPAA laws, you had to have a letter stating continuous coverage from employer to employer. And if you had even a little gap, they could deny you coverage, specifically of things related to your chronic condition, for, as far as I remember, up to 18 months. Wow. I know that was a danger for me when I first started. There was never going to be a time when I could take a job that did not come with it.
Right. It also took away these annual and lifetime caps on what we call essential benefits. And that's a big category. There are 10 categories. So I'm going to kind of just run down that list because I know when I think about all of them, it can make your head spin a little bit, but they're really, really important categories.
Right.
So I'm just going to list them, and they do play into this other part of the conversation that we're going to have. So they are ambulatory patient services, emergency services, hospitalization, maternity and newborn care, mental health and substance abuse disorder services, which includes behavioral health treatment, prescription drugs, rehabilitative and habilitative services and devices, laboratory services, preventative and wellness services, and chronic disease management. That's one category there. And finally, pediatric services, which includes oral and vision care. And it's really important to note that dental, oral, vision care is not considered essential for adults. So just putting that caveat there also. But
which is ridiculous, but you know.
Okay, but it is there for children. Right. So those are the major overlying essential health benefits. So, you know, this was all part of ACA, as well as our insurance premiums that can be subsidized to assist households whose incomes fall between 100 to 400% of the federal poverty line. So they can have that access, right? The health marketplaces were developed, risk adjustment programs were developed. Right. So this all falls, it was so radical in every manner possible to think about health, and how people can access health care, right? So, and also I think equally as important to note is there was a lot of controversy before it was passed, before ACA was passed, that people thought the costs were going to skyrocket. And in fact, we've seen them slow significantly. Right. And in many respects, certain aspects have dropped.
Right.
There are challenges. There are definitely pieces to it that need a lot of work.
Yeah, and I just touching on what people's fears were back then. So almost as soon as it was passed, there were efforts to take it apart, sort of nitpicking efforts. And one of those things was that originally there were supposed to be something called risk corridors that basically all the private health insurance companies who offered options through the federal or state programs would be subsidized for any losses. And that program was defunded. So you did see in the beginning couple of years some higher spikes, but things are starting to even out a little bit as the insurance companies actually start to make money on these programs. So yeah, there are always growing pains.
Yes.
We've made it through. And now we're moving forward.
Right. So let's kind of, I think really the driving force to create this podcast is really to have the tough kind of conversation about the very real possibility of what might happen if ACA is repealed. And as you said, it's much harder to take away from people once they've already been given and seen such benefit. But let's kind of talk about what's going on now with some changes in legislation, and there are lawsuits, and there's, as we record in July, there are things that are coming to fruition over the next week or so that we'll know more by the time we actually publish this podcast.
That's right. So the ACA has been challenged in the Supreme Court twice and survived. But when the current administration came into power, it was seen as very favorable to those who really wanted to repeal the act in its entirety. So in 2017, when President Trump passed the tax cuts, part of that tax cut was to minimize the penalty for not having insurance and make it zero. So not to get into the weeds too much, but one of the ways that they ensured participation in the ACA was by saying you must have insurance or else you get a penalty. And the latest Supreme Court ruling was to say that penalty was actually a tax, which means that Congress has the ability to enforce it. But when they zeroed out the tax, there are some parties who say that because it's not a tax anymore, but the penalty still exists, even though it has no teeth, it's not constitutional because Congress does not have the right to impose a penalty. So I believe it's 20 attorneys general from states across the country have challenged the ACA as a whole. They took it to a federal court in Texas, and a few months ago, the judge in Texas said the ACA is unconstitutional, but it can keep on going until all the appeals processes are executed. And his arguments for why it's unconstitutional have to do with the intent of Congress as it regards this law. So he argues that the intent of Congress is to have it work as a whole, which is to say, if you don't have this part, this individual mandate penalty part, then you can't have any of the law. The problem with that is that we've been operating under that for several months, even after the judgment, as well as if you look at what the ACA actually is, it's a series of programs as opposed to one giant program. And then the other part that makes it into his argument has to do with something called severability, which can you sever the individual mandate from the rest of the law, so take it away, and still have the law act as it's supposed to act. And as with the previous argument, considering that that's what we're doing right now,
it would seem the answer is yes.
Right,
you
exactly.
could take that piece out from the individual mandate, and the rest of the law still functions as it had been intended.
Exactly.
So,
and that's the first part.
Okay.
The second part is that I believe it's either 16 or 18 attorneys general on the other side plus the House of Representatives on the federal level have said, nope, we're going to challenge this. We're going to appeal it. So just on Tuesday, so what's today, the 11th? So on the 9th of July,
Yes.
The Fifth Circuit Appeals Court in New Orleans heard arguments about a couple of things. So they heard this whole case again, so they can either choose to confirm the Texas judge's ruling or to overturn it. But there's also a question of whether the states that are appealing in the House of Representatives have standing. So that means that do these states coming forward have a right to challenge the ruling? Are they going to be hurt by it? So since nothing's happened yet, they can't say that they've actually been hurt by it. But I think that there's enough previous cases or precedent that say that they can move forward with it. But it is a challenge, and it's a serious challenge. So there's that part of it. And common thinking is that whether the ruling is affirmed or overturned, it's going to go to the Supreme Court.
Again.
So for the
third time.
Right. So if it's overturned, or even if it's affirmed, one option the Supreme Court would have is to say, we're not taking this case, which means whatever the lower court decides stands. So it'll be interesting, especially dropping this particular issue into the 2020 election cycle, after everybody saw that healthcare was the number one driving factor of 2018 voters.
Right.
So it can be a catch-22 to the ACA's opponents. Even if they get what they've been trying for years.
Right.
So
all that nice background, because it is complex.
It is.
It is complex, just like healthcare in general.
Yeah.
You take out all the legalities. Healthcare is complex. Taking care, and I mean that on a personal level. I don't even mean it in terms of how we interface with our physicians and insurance companies. I just mean we're complex beings. Right. Our bodies are complex, and that's pretty rough. So let's talk about what we have to lose.
A lot.
I mean, it's obvious it's a lot, because as we're talking and we hear all the complexities, but there are as many as 21 million people that could flat out lose coverage.
Yep. Yeah. Most of the exchanges, and a lot through Medicaid, actually it's about equal, looking at the numbers right now.
Right.
And almost 10 million who receive subsidies to help to help deal with their premiums.
Right. And when you say that, Claire, I think our Gaucher community is incredibly sensitive to that particular topic. In fact, the National Gaucher Foundation also has a subsidiary, the National Gaucher Care Foundation, and we do run a patient assistance program specifically set up to help those who are eligible to have Gaucher.
Do you get federal funding through the ACA?
Not through the ACA, but we do provide grants to those who are eligible, and to help them access their health insurance by being able to afford premiums, which are expensive. So that's a big thing. So plenty of people receive subsidies, and even with subsidies, it still is a real tough nut for most people. I would venture to bet that paying for health insurance or their health care, which includes the health insurance, is if not equally or more expensive than even their homes,
right? I was thinking
whether it's rent
or cars,
right? Even more so than cars. That's almost like the obvious, right, to me. But putting a roof over your head, whatever that may mean, healthcare is got to be, if not right below it, equal to it, or
if
even above it, right? And
Yep.
so this is significant,
right? And that's not even counting what your bills would go up to if you don't have coverage.
Correct.
Right. So, because my understanding is that many of the treatments for Gauchers are quite expensive.
Yes.
Yes,
they
so
are.
we can start there.
Right.
The caps would go away.
Right, the caps would go away.
So you have the catastrophic care costs, with coverage or without coverage, that would stop sometimes at $1 million in your lifetime.
Right.
Not a year, in your lifetime.
Right.
And that's, I mean, I'm diabetic and I know how much my supplies cost. I'm not saying I would approach what Gaucher's patients have to pay, but I am almost certain I would go broke.
Right. Well, and that is the position that basically everyone within the Gaucher community would be in.
It's terrifying.
And in a very, very short period of time.
Right. Because how do you decide that? We already have people still having to make decisions about whether they get their regular medication or whether they pay for groceries every month.
Right.
But, there is no option
Correct.
if you don't have caps on, if you don't remove the caps on lifetime
Correct.
payments.
Correct.
So that's one.
Right. And all those essential health benefits that we went through, that whole list that we're all thinking to ourselves, they're no-brainers. We shouldn't even be thinking twice about that kind of these essential health pieces. They shouldn't even be called benefits.
Because they're not, right? They're, I don't know, we can't call them entitlements, but it's kind of what we are. We as human beings are entitled to live our lives.
Correct.
And those essential health benefits really sort of pave the way for even the most basic.
Yes.
And one thing that I don't think we mentioned before was that preventive services are free right now. So your annual physical and some of your lab tests, they're free.
Correct.
Just to make sure that you catch things before they get out of hand.
Right.
So there's no barrier, which
is actually more cost effective than not.
Right.
Because if there is almost an incentive, it's not really an incentive, but if someone knows, well, I can go for my well check, and it's not going to cost me any more than what I'm already paying for my coverage, then that's a great thing. Well, if you take that away and somebody isn't, interfacing with their physician on at least that annual basis, the problems that could arise
are significant.
They're significant. It could be devastating, both from a medical standpoint, but also from a financial standpoint.
Absolutely. One other thing is, if you have kids, they may or may not be able to stay on your plan until they're 26.
Right.
Previously, it was 23, but I think that was more the private health insurance company's decision that they were allowing you to do that. I don't think that was a law anymore that said that they had to do that. But the ACA says that they have to cover your children until they're 26. So you're going to have a crop of new college graduates who may or may not be able to find insurance if they have some kind of chronic condition, including Gaucher's.
Or afford it.
Right.
Just coming out of, whether it be college, if they've gone to college, or they're still getting their feet on the ground, even if they're a high school graduate and they've had some fantastic voc training in some, field.
Right.
But they're just still so new.
Right.
That in essence, it could be in many respects or in many cases that parents would be paying for that too, which is a premium and deductible and all of that, or not, and which means
and
I'm not going to the doctor then.
Right. And sometimes the option is COBRA, which I'm hoping that none of you have ever had to deal with COBRA. But COBRA is usually at least twice as expensive as whatever you're paying per month.
Correct.
I've only had to use it once. It was a nightmare. It was very last minute. And I am hoping in my lifetime to never have to use it ever again.
Right. It's that bitter pill of, well, at least it's there, but it's a rough one. It's a real rough one.
Yeah, for me I thought I was going to be without health insurance for a week, which would have been fine, but it turned out I was going to be without health insurance for a month, which that's just a little bit too high a risk for me to go down that road.
Right. So, and then there's also mandatory coverage now, which would be lost, and we don't think about this. And one affects families in general, which is access to birth control without having to pay an exorbitant amount. And then the other is also family related, but personal to women, which is if they choose to breastfeed their children, their babies, then right now there is under ACA, they can access that kind of care and help without additional costs.
Sometimes it's hard.
Right.
I learned that from my sister-in-law. Sometimes it's not just you put the baby up to your breast and it starts. Sometimes it gets a little bit more complicated.
Correct. And so those are some of the built-ins that right now we're not thinking about, but they are some of the obvious.
Right.
And though we could sit here and talk about the challenges in terms of pricing for pharmaceuticals, and by far there really are, that is the reality, and more needs to be done. But there are some pieces built into ACA that are already there and set up and are protecting us in some way. Not enough.
Right.
Not enough. But
it's a step from what it was
It's a step
before.
from what it was. Right. So that would be lost too. Those kinds of protections or these denials of coverage, retroactive cancellations, these kinds of things would reappear.
Right.
They would rear their ugly heads yet again.
Yeah, the bad old days is how I always thought about it.
Right. And something as simple, not so simple, high blood pressure, right? Common. Something as common, right? As high blood pressure.
That.
Right? That could be enough to qualify someone as having a pre-existing condition that would not enable them to get coverage.
That's right. Because high blood pressure can lead to a lot of other types of complications, expensive complications. And even if you were diagnosed the day before your coverage started, the insurance company would have the right to say, no, we don't want to do that for whatever period of time, if at all.
Right, we won't cover that. There are rights that people have now in terms of being protected from their employer saying, no, you can't be in our group plan. We're not going to.
Yep. The high-risk pools.
High-risk pools, right?
That's right.
That would disappear as well. And part of what ACA has been helpful for in terms of the work-related is small businesses.
Yes. It's interesting. I started the blog with the idea that I might make it into a business. I'm still considering it, but if the option for the ACA goes away, there's no way I can do it.
Right.
Flat out, there is no way.
Right. And just so that our listeners, if you're joining us and you're tapping in a little bit late, or you've kind of fast forwarded through some of this stuff. So Claire has a phenomenal weekly blog.
Thank you.
The Patient Advocates Chronicle. It is a tremendous resource for those in any community that are affected by any kind of health.
Chronic and autoimmune,
health. And there are many.
And there are so many issues that cross all diseases.
Right.
So occasionally I'll talk about my disease, but it's not disease specific.
Correct. But one more thing in terms of work, we're talking about ACA and what devastation could occur should it be repealed. I don't know that many people think about retiring early, but that would not be an option.
Before aging into Medicare.
Correct.
That's right. So you'd have to have, if you're going to do that without Medicare, you would have to have basically an old school pension from your private employer. And let's face it, how often does that happen?
It doesn't anymore. It's almost non-existent.
So if you want to do that, join the military now, spend 20 years, and they'll cover you for the rest of your life.
Right. And then obviously the premiums would jump.
Absolutely.
Again, we saw a hike, and they were steep hikes when we first started with ACA. They were painful for most people.
Yep.
But I think that's also reflective of shifting the mentality to, okay, so if this is a right for all of us, I think that's a reflection for shifting our mentality to health and healthcare, access to healthcare is a right for all of us. And so if we're bringing more people in and clearly some really can't afford,
right,
Others can very easily afford. And then there's most of us, it's the bell curve. And then there's most of us who fall somewhere in the middle, which is, it's a challenge, but we can do it. So we never know when we're going to be in the place of, I can't. So we're there as a community, a broader community. So if it means I have to pay a little bit more, then I would really like to make sure that those who really can't are balanced in a little bit better. That's kind of where it comes from. But overall, in the scheme of things, what we're getting for our healthcare now, there's so much value, so much more value. Yeah. And I think many people are also starting to see that their premiums are dropping.
Yeah. And it's interesting because I know people don't like to talk about it this way, but let's be honest, it is a little bit of wealth distribution. And I have a lot of friends who are healthy and reasonably young who resent it and say, why should I have to pay for somebody else's health care? Right. And I look at them and I say, oh, you think you're going to spend your entire life on this planet without needing it yourself? And that's what they think. Right. And it's, just wait, because the most that is spent on healthcare is end-of-life care. And in this country, where we're very concerned about extending life, perhaps even over quality of life, it gets very expensive in the end.
It does. It gets extremely expensive. And so we've now hit all of the obvious.
Right.
And that's a lot. Mm-hmm. And that's a lot that I think most of us are more comfortable with knowing that we have access to.
Right.
And this is no longer a struggle or a worry in the same way. Mm-hmm. So let's talk about the not so obvious.
Right. There are a lot of things that have happened throughout the country, actually, that people they don't associate it with the ACA, or they don't realize it's happening.
Right.
So yeah, there's a lot.
Okay. So let's talk about, we've talked about the lifetime coverage and caps and really that's enough to bankrupt people. And we've touched on that, but there's something that used to be referred to, still is referred to, but we don't really talk about it as much, these skinny plans.
So the skinny plans are basically plans that are not required to, include all of the essential health benefits, and they're not really held up to the standards of the ACA. Now, these plans were allowed under the Obama administration as temporary plans. They're, limited to a few months. I don't remember exactly what the figure was as far as number of months, but the current administration has expanded that, I believe, so that they can be offered to just under a year. So you can keep renewing these over and over and over again, and people are sort of drawn into this because they don't understand what's not in the coverage, and they're much less expensive. So it's, for someone like us who has a health condition, it's an awful option because it just isn't going to robustly cover what we need to be covered. But for all those people who may be on a track to develop or they're undiagnosed, they're going to buy these plans thinking they're healthy, and all of a sudden, on diagnosis, they got nothing.
Right. And then you've got the pre-existing condition piece again.
Right.
But the other piece is for a community like ours with Gaucher, a community of those who have diabetes or any other chronic illness, become very savvy about your own health and healthcare in general. But when you talk about the rest of the population who tend to be seemingly healthy, right, with very little thought to what's going on, they don't understand how to read these plans. And we've done, you've sat here with me before, we've had these conversations about healthcare, right? Like 101 and legislation. And we've done previous podcasts with Aviva Rosenberg, who is wonderful also about just the basics of what do you need to know. They are almost purposefully written in a very convoluted manner and very hard to understand. So unless you really you really know what you need, you understand how the policies work, you could really get trapped into something that is not sufficient coverage for you, won't best meet your needs, have hidden expenses elsewhere. And that's exactly what you're talking about with these skinny plans that could really happen.
And they can, it's even more basic than that. It's the language. Nobody understands what an allowance is.
Right.
An allowance is, under the plan, what is allowed or disallowed. So, for most plans, they send you these shiny 2-page brochures that give you an outline, a very light outline, but they don't ever show you something called the summary plan description, which has the grids of everything that is covered. And that's not even the whole plan that's been approved by the insurance commissioner in your state. So they can use a combination of language, the appearance that they've shown you what the plan is, and our own, ignorance against us, whether we know we're being ignorant or not. I mean, I have smart friends who have gone through this process. They're attorneys. They're used to complicated language. They can't get through their own health insurance policies.
Right.
So and the fact that they're selling these plans primarily is less expensive without elaborating what is or isn't going to be covered, because they don't. It's deceptive. To me, that is a reportable Better Business Bureau deceptive practice offense. But, it's legal.
Right. And so you have to be a savvy customer, which is really a lot of why tackling these kinds of topics and conversations in a podcast like this for our community is so important, because we want to give our community what to think about. We want to empower them with knowledge. And then, of course, when we get to the end, we'll talk about, well, what does that mean and what can you do? But let's just keep going through the not so obvious, right?
Okay.
So we mentioned before, right, there were two big pieces. We've talked a lot about the insurance mandates and the marketplace mandates and how those really changed. What we really didn't talk about was the Medicaid expansion as much. So let's talk about that, and then we can talk about the not so obvious is what that's going to mean with the rollback. If ACA were to be repealed, we've gained stuff now. What we've gained with Medicaid and who can now be covered with that. And if ACA is repealed, then that gets rolled back. So let's talk about that.
So the Medicaid expansion was a policy under the ACA where states could come to the federal government and say, we want to be able to expand our Medicaid offerings, whether that's to a greater population or greater services. And the best part about it was that the federal government would pick up all of the tab. I think the figure that I'm seeing in my head is states would have to pay about 3%.
Right.
Don't quote me if I'm wrong, but it's something along those lines. And so that's going to expand the ability of these states to reach their most endangered populations.
And again, that becomes preventative to a large extent.
Yeah,
right?
Which is cheaper.
Which is cheaper than it is to retroactively try to go back and mediate health issues.
And shockingly, not all states jumped on board right away. But it's been interesting to see that some of the more reluctant states have been slowly getting closer and closer and closer. And Maine is a very interesting case study because they put it on their ballot and the voters said, yes, we want it. And the governor, who I think is no longer in power, said, well, I'm not going to give it to you.
Maybe that's why.
He's no longer in power. Right. So it's, I want to say about 2/3 of states have it now. There's still a lot of holdouts, but it's basically free federal money going to the states to help their populations.
Right.
And all that they could rescind it very easily.
Which would be devastating for many, many, many people.
Yep.
Okay. So how about high-risk pools?
High-risk pools. I hate high-risk pools. So the idea of high-risk pools is that the government or the insurance company can stick all of the sick people together in one giant pool and then have all the healthy people in another pool. So guess how not advantageous that would be to
For
people
our
who
community.
can't really afford it. Right. Us. So right now, you can't really do that because the whole idea behind the ACA is the distribution
Is by your age.
by age and not condition.
Not condition.
Right. So it's it would just turn everything on its head, and it would essentially take us right back to where we were. Any mention of high-risk pools, if you ever hear anyone talking about it or an article about it, that should be sending, alarm bells off in your head.
And, yes, this is a podcast here for the Gaucher community, but there's a crisis going on in this country that is talked about and kind of hushed away, but talked about and hushed away, and that would be the opiate crisis. And this is a perfect example of people who have, for the multitude of reasons, developed an addiction to opioids, pain medication.
Right, and keep in mind that the developers of the drug and the marketers of the drug had a big hand in concealing how addictive it was. Right. So it's not all on the patient. Correct. That they ended up addicted.
Correct, but right now, part of what is the ACA mandates that coverage of substance abuse treatment. Right. And we know that it's still not enough, right? That's part of what that's a piece of the crisis. For our Gaucher community, there are percentages of the community that have a lot of pain. They have bone pain, they have, and pain management has been a big deal. And even if they've been working with a physician and have, it's become more challenging for them. Right. And
because people are getting very wary.
Correct. And so it's put different obstacles out there. And, but the gist is when you have these risk pools and you put them back into effect with a repeal of ACA, it will be devastating across the board.
It will. And I think that the opioid addiction community will get hit very hard.
Yeah. And it's a big age range also. So that's it's not even going to look at that.
Right.
Medicare premiums, co-pays.
Right. So without the free preventive care that we were talking about before, all of that gets added back into your healthcare premiums and, how insurance companies spread out what they charge you anyway. So it's just going to be an increase because some of those lab tests and x-rays and things like that can get very expensive without coverage. So Medicare premiums would go up,
Right.
It's interesting. I'm not sure how aware people are that you actually do have to pay for Medicare. You can age into it, but it's not a free service of the government. Right. And so you have...
Comes out of Social Security.
Right. And you have, so the older population that, is more often than not retired at this point. So they're not going to have money coming in on a regular basis sometimes other than their Social Security. So they still have to make room for Medicare. And it's not really a population that can afford premiums either, higher premiums either.
Right.
So that would be one of the things that changes also, along with prescription costs. We're trying the big push federally and some in the states too, is to lower drug costs. So this would sort of work against bipartisan efforts to do this.
Correct. And then our healthcare providers themselves, our physicians, the hospitals, they would be negatively impacted as well.
Right. Right now, there are government negotiated rates, and those would be put back in the hands of private insurers, which at least when you're dealing with Medicare and Medicaid, you're guaranteed payment. But if you're priced out of of the market. And, some places it's going to be a stranglehold because you only have one hospital in so big an area.
Correct.
Serving, maybe not as big a population as you would have a city has, 4 or 5 hospitals maybe. So it's similar to the financial markets where competition helps. But if there is none, the insurance companies can say, well, we can't afford to cover whatever you have to charge to stay open.
Right.
So.
Correct. And then we have what's often referred to as a pink tax.
Yep.
And it applies to women, but it affects everybody.
It does, because usually there's somebody else involved.
Correct.
in the baby process. So what they would do here was, if you are a woman, an insurance company could increase your premiums just based on the fact that you might have a baby.
Correct.
Now, speaking for myself, I am not planning on having children, and I know a lot of women in my peer group who aren't. But that's not really going to matter to the insurance companies. They're going to say, well, you could.
Right.
So we're going to add on X amount.
Right. And then there are 2 more pieces, which are the not so obvious that let's just touch upon, which is something that I don't know that most people really think about.
They're much more general.
They're so general,
right.
but it's there now. So
right.
One are all of these nutritional and caloric counts for chain restaurants that we walk into a place here or there now and we see that, oh, it's so many calories and whatever.
Which might actually affect what you order. I know it does for me sometimes. It's a mental check on myself. I can't eat 1,000 calories in one meal.
Right.
It just makes me feel ill.
Well, for most people, but I think that sometimes when you go in, before we had any of these nutritional calorie count, identifications on any menus,
right?
Sometimes something would sound like, oh, but that's a salad. That's gotta be healthier than whatever the other item is. But in fact, perhaps what is in that particular salad may really make it not so nutritionally beneficial and bump those calorie counts and all sorts of other things.
I can think of a few chains they're very good at making salads be 2,000 calories. They shall remain nameless, and the salads are very good.
Right.
But it is a little...
Right. So it just helps people be more aware so that they can make healthy choices.
Right. And anyone who's watching their meal plans or wishes to be aware of what they take in, it's going to be up to the restaurants and the food companies as opposed to, what the patient is really looking for.
It's an opt-in choice, which who's going to want to do that if it's going to...
Extra effort
and perhaps maybe not help the business as much as they might hope.
Right, exactly.
And then finally...
and this is a little bit bigger than calorie counts.
It's bigger than calorie counts, but when ACA is in place and our healthcare costs are lower, there is a definite benefit to the economy.
Yep.
Because that means that we all are not just hopefully feeling better, because we're taking care of ourselves in ways that we wouldn't necessarily just do. But it also means that there's more money in our pockets, and more money in our pockets then turns around and translates to more money being spent in other areas.
Buy some fun clothes maybe, or, take an extra class somewhere.
Save up, go on a vacation, go tour, do something, right?
Right. And I know that, say the ACA is repealed and, they limit my coverage again, I know that I am going to be saving every single penny for that rainy day when disaster strikes and I need every cent to pay for a medical issue.
Right.
So that it'll definitely slow things down.
Right. And also the Economic Policy Institute estimates that quite a number of jobs will be lost.
Yep. Right now, our healthcare costs account for, I want to say about 20% of our economy right now.
Okay.
So if we have to increase those and we're not spending, then retail that's already in trouble is going to go bye-bye.
Right.
You know, places that we go to spend all that, you know, not extra cash, but more flexible cash.
Yes.
Restaurants, you know, movies, whatever you do on date night.
Right.
There's just not going to be a market for it.
Right. So, and those are all really, they're the not so obvious, but they are incredibly impactful repercussions should ACA be appealed. And so this brings us, as we're winding down our time with you today, but it brings us to something so important. And we've said it before, almost every time we've had a conversation and had you be our subject matter expert.
It's one of my favorite soapboxes.
Which is?
You have a voice. Every single person in this country has a voice. And considering the people who make the laws, their primary objective is to keep their jobs, it's always important to hear from the people who can take it away. So if you feel strongly about what's going on, call or email or write your legislators, not just on the federal level, on the state level too. There are a lot of states that are looking at what's going on and saying, well, worst case scenario, and this gets repealed, what are we going to do for the people who live here? So they're starting to institute some protections. One of the states just instituted a state level protection for people with pre-existing conditions.
Really?
Yeah, and I forget what it is, and I think I just wrote about it, so it's bad that I forgot what it is. But I'm hoping it's going to be a domino.
Which would be a great.
Yeah.
Yeah.
Yeah, it would be really nice to have that on the state level because unless there is a federal law in place addressing it, state laws will stand. So yeah, I personally use vote.org because vote.org will let you see if you're registered to vote. It will allow you to register to vote if you're not on the right list, and it will give you all of your legislators at every level based on your address.
And typically when we publish our podcast, we also publish a summary of the podcast, and we will make sure that we have our resources incorporated so that our listeners can be on our website and they can see such a reference as well, and be able to have their voice heard as they feel appropriate. It's all about choice.
Right. And I just want to add one more thing to that if you are comfortable with it, it's always more effective to share your personal story. Stories are what can make people cry. Stories are what can make people angry. And all of that strong emotion is what makes people that you've never met want to act. So if you can, and there are a lot of people out there who do not feel comfortable sharing their stories, even though they're so impactful. It's a very private thing. But if you can share even a little bit of your personal story with whoever is on the end of that line, it's going to have an effect. I guarantee it.
And the more personally our legislators feel for their constituents, the more likely they are to really understand how ACA is affecting our lives.
Right.
And hopefully, I think for our community and the greater American community, it is a positive in so many ways. And they'll have a sense of just how devastating it
will be.
Not even can be, will be if it's repealed.
Right, exactly.
So, well, that's all the time we have for today. Thank you so much, Claire, for sharing your insights.
This was a lot of fun.
It's always fun when you're here. And this is such an important topic. I'm delighted that we've had a chance to discuss it. We're very, very grateful for your time. So thank you.
You are very welcome. Thanks for having me.
We will have you back, I'm sure.
Great.
And thank you to our listeners. If you want to learn more about Gaucher disease or the National Gaucher Foundation, please visit us at gaucherdisease.org. That's GAUCHERDISEASE.org. You can sign up for our monthly newsletter, read articles and blog posts about living with Gaucher disease, as well as patient stories and videos. You can also follow us on Facebook. Please check back for future podcasts from the National Gaucher Foundation. Thank you, and we hope you'll join us again next time.